We've got a wealth of hospital data, uh, which we all wish we could leverage. And Antony is one of the people who has made some progress in that direction. He's going to share with us, I'm sure, today. I'll just mention briefly that he has also established Canada's first health informatics fellowship for emergency residents. So thank you.
Thank you very much for the introduction. All right, so I guess it's good afternoon, everyone. It's past noon. Hope you enjoy the pizza. And if you want to listen to me, I'm here. I'm going to be talking. Feel free to interrupt me at any moment if you have any questions, any comments, thoughts, if things are not clear. I think of this more of a lunch and discussion. So I'm talking here, but we're all here as a group to kind of share and learn from each other. So I'll just get started. There's a lot of fancy words that were said up to now. Essentially, I'm just trying to make things better. It comes down to that. How do I make things better in the work environment that I'm in? Working in engineering before medicine, I like to think of things as processes, steps. How do I make this machinery better, or how do I make the workflow better? How do I make the processes better? So I have no conflicts of interest yet. I'm still waiting for that one breakthrough that's going to set me apart, and I'll add a list and list of things to say. So what I'm going to talk about today is where do these, projects come up from? How do we come up with these ideas? What kind of projects we worked on in the emergency department? The infrastructure for this data access that Nandini was mentioning, how I do know that it's quite hard to get the data and to be able to do projects that are exciting. And I've been privileged to have access to this, and I'll explain how. And how a lot of collaborations have helped foster these projects and help them get to fruition. Some are published, some are in writing, others are going to be more quality improvements that will never be published. And then what I like to end with is the idea of where can we go from here and how can we collaborate with the emergency department to make things better. What's not covered here is this is not a presentation on a project or a few projects and the outcomes and the publications or the results, methodology. It's not that part because I feel like here most of you understand methodologies and projects and research. It's more how in the emergency department we manage to garner data to do things. So, I've only started my career about 7 years ago in the emergency department. Prior to that, a lot of people have worked to make our emergency department at the MUHC digital. So most of the time, I'm using a keyboard, voice recognition, a computer screen when I'm not seeing a patient. Rarely do I grab a paper and a pen. So that's our emergency department at the MGH and the Glen. It's not the same across Quebec, and it's not the same up on the wards of different parts of our hospital. That's because my colleagues have managed to set up this infrastructure where data is collected electronically through clicks, through typing, through voice commands. And most of what I use is electronic. So again, I don't create paper and I don't use paper. Everything is organized in a really nice way. Once in a while, when I'm outside the McGill electronic record system that we use in the emergency department, I use Oasis PACS, the DSQ, which some of you may have heard of. And just a little bit of my perspective on innovation, right? So the goal and what I'm trying to achieve and try to do is essentially help us clinicians treat patients better diagnostics, be more accurate, more effective in order to improve outcomes, as well as, for patients, improve their well-being, to improve their satisfaction, their experience in the emergency department. All of this are these broad lines, healthcare innovations to improve potentially the quality, potentially improve on cost, safety, efficiency. Again, these are a lot of words, but at the end of the day, it comes down to how can we make better. So in the emergency department, we often talk about wait times, and that's truly one of the bigger problems that we have, as well as access to data for clinical work. And the access is limited because we have many software systems that you have to open, you have to go and get the information. It doesn't come to you as we know technology can do today, bring you the information at the right time in the right place. So efficiency, the goal is improve efficiency of care along the whole spectrum of it. The quality as well is very important, in terms of outcome need to be better, optimize the time to pain control, or how well we control the pain, or how well we treat an illness, and safety for patients to have reduced the adverse events. So this is where I sit. I like to look at these kind of projects that come up to me while I'm working. So where do these projects come from? Think of myself working as a physician in the emergency department, but I have another person next to me in my head that's standing around just watching. So that's the engineer in me who's trained to look at processes, workflows, how things happen, how things should be, where efficiency needs to be improved. So, there's two people that are in the emergency department when I'm working, myself and this engineer inside of me, who still, despite graduating almost 2 decades ago, is still there, still present, still running inside. So I'll give you a couple of little examples just to kind of, get you thinking. And just before, I know some of you are clinicians. Could I just get a hands of those who are actively practicing medicine or those who are more research? So clinical medicine, okay, and everybody's more on the research side of things. Okay. So it's more on the research side than the active clinical. So some of the example are just simple ideas to bring in. So if a patient comes in and we're going to talk to the patient, we're going to evaluate the patient, and then quickly we turn our minds to the monitors that are around them, looking at vital signs, talking to our colleagues, looking at computers to see their data, their past medical records. Patients will often tell us, doctor, you're asking me all these questions. I've already told the nurse, why don't you look at her note? Or why don't you look in my file? You'll see all the treatments that I've gotten. I don't want to repeat them. And it's true. Why do they have to repeat this information? Well, in the emergency departments, I don't have time to look at their chart before I go see them because I need to focus on my time to be effective in treating their problem. So I might go see them, ask them a couple questions, get an idea what is the main problem, and then selectively look to their chart. So, but the idea being a lot of things are in their chart. And we'll get an ECG and we'll look at it and say, oh, this patient has an atrial fibrillation in this case. So we have to choose our treatment. Which treatment is better? Which one is more effective? Some of this, pure research has been done at other centers, and some are prospective trials, some are retrospective. But then at the end of the day, we try to see how does that affect, time to disposition, time to going home, time to getting admitted in the hospital. These are the metrics we'll be looking at. Another project, that could be in the emergency department would be someone comes in with a fall, they have pain, and they're waiting. So you see at the top left, the wait times, there's different kind of priorities. So they're waiting in the emergency department. They eventually get an X-ray, they'll get a diagnosis, they'll get a management, and then they'll leave. And often they'll be dissatisfied. I've been waiting in the emergency room for 4, 6, 8, 12 hours. I'm still in pain. It took long to get a diagnosis. I've seen people walking around smiling on their phones, going in and out of rooms. Why am I waiting? So often the question is the experience of the user in the waiting room is not great. So when I think of projects from different perspectives. So some of it are a very traditional systems approach, right? Others will be based on the user, whether it's a patient, a clinician, an administrator, or you can look at the data itself and then reflect on the data's perspective. So quickly and briefly, I mentioned, systems perspective, and this is not, systems health engineering or systems thinking. It's more, if you look at the system that we're in, we have, services, different departments working together, including the emergency department, the admitting services, the consultation services, the cleaning staff, and the, administration coordinators, a lot of people working there from different departments. And we have the infrastructure and we use the computer system, the networks, the Wi-Fi, the softwares, and if you want to look at an example that's very tangible today is the use of AI scribes. So this helps from a system perspective to improve the time it takes for everyone to document. Now, Santé Québec has made some recommendations. The adoption is not quite uniform yet, but it has a potential to affect the system to be more efficient, to decrease the time it takes to click, the type while speaking. Now, it does have its own problems. I'm not really here to debate that today, but the idea being you can think from a system perspective and improve things. You can change the computer systems, the softwares. So Santé Québec's planning to implement one hospital record system across the entire province called Epic. So that's another bigger system perspective of changing things. Then you can look at the individuals that are part of this whole healthcare system. So you have clinicians of all sorts, patients and their caregivers, and administrators. So one of the projects that we've done was to evaluate patients' perspective in the waiting room, what kind of information they want, how they want that data to be communicated to them. It helps to kind of improve the system. So you can go by individuals that are in the system. Or what I like to do a lot is look at the data and try to learn from the data to make things better. So, the types of data we'll see in our record systems include patients' demographics, who they are, where they live, when they arrived to the emergency department, when they left the department, when they click to get that ticket, that's the very beginning of their care. The triage information, when the nurse evaluates their complaints, their problems, and documents the vital signs, the heart rate, the oxygen saturation, the reason why they presented to the emergency department. Then you have the medication, the labs, the imaging, the investigation that we do in the department, the consultations that we request. Somebody has a fracture, may need an orthopedic consult in the hospital or outside. if they get admitted or not, and then electronic notes. So electronic notes is a very large data source that has been difficult to capture and organize given its an unstructured nature. But now with modern technology, there's a bit of ease of getting into that. And one thing that I really sets me apart from the rest of my team is looking at the timestamp of all of these events. So looking at the emergency department as a series of events from patient clicking, getting a ticket to getting an order of a medication for their pain, when the medication is given to them, when they get their x-ray, when they leave. So looking at these timestamps allows you to better understand efficiency and gaps in efficiency and how things could be better. So I'll just do a simple example to better understand, and I'm sorry about these overlapping titles. I made a change in the color of the backgrounds and then changed the theme, and therefore we get this issue. Not a big deal. Here, this diagram is not really for us to look into detail, but it's the idea that to understand the data, you have to have an understanding of the clinical workflow. So this is a very simple one where the person on the far left comes in, gets triaged, and eventually goes into the waiting room to wait for an evaluation, gets seen by a physician, that's the pink box there, gets an x-ray, goes back to wait for results, gets another evaluation. So you understand the idea of workflow. What are the things that happen? And to me, when I see this, I see timestamps. Like when was the patient triage? When did they get the evaluation by the clinician? When did they get their x-ray? So this is how our projects, and especially the ones I work, are initiated. And I have some of my colleagues who do different projects. So I'll think of it from, myself as a clinician or my colleagues, and what are the complaints? Some of them will complain that they have, they're frustrated of clicking too much to get to the information or to provide a treatment for the patient. Or some of them are motivated to learn, to know how can I be better as a physician? What could I do to improve my efficiency, my workflow, my performance? Some complain that there's too many softwares to open, or there's delays in a simple management of a patient that the blood test takes too long, or a novel test can come in that can expedite the workup, or how do I prioritize which consults we can see? So again, I just give you a list of complaints that came from a physician that led to a project. So the clicking, we decided to assess the impact of touchscreens. So if instead of clicking with the mouse, we have to drop the mouse, use a keyboard, go back to the mouse, what if your hand was touching a touchscreen? We assessed it in a sort of simulated environment. We found that touchscreen don't necessarily make things better or worse. And the problem being the software not designed for touchscreen. So because of the software that we have is very small click boxes, a finger is too big to kind of make it more effective. So if you redesign the software, you maybe have an improvement. So that was one of my early projects to understand how to measure clicks, number of clicks to get to a certain action, the time it takes. Then those were motivated to improve, wanted to have their own dashboard of their performance. How many patients did I see? The time that I took to discharge them. The third point is actually a current project. We're trying to organize all the data in one place so you don't have to open every single software. And it's actually going quite well. I have a colleague telling me, it took 10 clicks less to get to a certain image of a patient than it took before. And that 10 clicks translates into maybe 5-10 seconds for the 200 patients we see in the emergency department that get imaging. That translates into hours over, days and weeks and months, and eventually will have an impact. So if you do many little projects that improve clicks or time to clicks in different places, do make an impact in the big scheme. And if you can look at all as well from our nursing colleagues. So this is a new project that I was working on with Nisha's help, is to understand, how would AI scribes, which is using a microphone, listening to the conversation and creating a summarized note for the nurse at triage, how could that help their time to triage or their quality of? And that came from, nursing finding that a lot of triage is not equal. For the same presentation, different nurses will document differently. So to standardize that or to make it faster, we thought, we could do a project where we can assess. And again, why? Because we have the timestamps. We have the timestamp of events happening throughout the care of the patient that we can evaluate. Other projects that we had done before, again, with Nisha's help and the technology assessment unit at the MUHC, is to look at nursing tasks. How long does it take to complete a task? So again, because we have MedSurge, where everything is documented electronically, we're able to extract that data and analyze. And we'll talk about how I managed to extract the data in a bit. To extract the data from an order of a urine test to the moment the test is collected and sent to the lab. Uh, we can go as far as getting the lab test result, but then you need to connect with the data warehouse to get lab results that we don't have access to. So I try to stay within the realm of MedJours because we have access to that data. For patients, we mentioned about the waiting room frustrations, a prolonged wait time to get an X-ray, or even in predictive algorithms, the use of gender and race, and how does that affect the models. So we've done a study looking at MIMIC data, which is a publicly available data set that you have to get permission to use, and to look at the presence or absence of the race variable on prediction outcomes. And it actually alters the predictions based on it. Whether it's reflection of reality, MIMIC is from the US, so there must be some connotation or correlation with reality there where people from different ethnicities may behave differently. So is the model predicting what the race variable does, or is it bringing in bias that we don't want? And for administration, we had implemented a new physician role at the MUHC called MD Kodo, and they wanted to know how did that impact patient workflow. So this is where the projects come from a complaint, from a problem, from potential ways to make things better. And with these collaborations, so when I say MedJours, that's the company was recently changed name to LGS Technologies, who has implemented MedJours at our site, but also provided us with a analyzer module. So inside of MedJours, you can go in and download with permissions the type of data that you want. So we want to get how many patients got a certain medication in this year. You can get all the patient visit numbers, not the patient information, but their visit as an identifier. And you'll get all the medication are prescribed to all these patients. And then you can go down into one specific medication. How often do we use medication X or Y or Z in the care or in the process? And then you can compare different medications. How often are we using one or the other? And having the diagnosis, you can start comparing. Okay, how often do we prescribe this antibiotic versus that antibiotic for this patient population presenting with a urine infection? I think there's a hand up. Yes.
Yeah. Yeah. So you can capture the medications given in the emergency room, not the medications the patient may have gotten yesterday or standardly takes.
Yes, exactly. So in the emergency department, the physicians are responsible for ordering the medications when the patient arrives or soon after. And we insert that in MedJours. And the nurses have the medication administration record to which they click or they see the schedule when the medication is supposed to be given and they confirm by clicking. So again, and that's what I was mentioning at the very beginning, the standing on the shoulders of giants. My colleagues have managed to build this infrastructure, allows me to come at the end and kind of benefit from all this data being electronically available. So collaborating with Tao, Mila, and all of you guys here, it's allowed me to kind of do this project. And Radonk is one of my buddies who did engineering with me, who now is in radiation oncology, but took the time to do a master's in artificial intelligence, which allows us to do predictive modeling projects. Okay, so let's talk about bridging this gap. So I've talked about clinical needs, problems leading to ideas of projects, but then you still need to do the projects in a more systematic, rigorous, standardized way. So to bridge this gap, you think about the clinical domain expertise that I've kind of brought up so far. Someone needs to understand the raw data here. Someone needs to be able to look at data warehouses, databases to access that information, to analyze and explore it in a systematic way to make sure you're capturing, cleaning appropriately the data, and then the scientific methodology to answer the question. Maybe by show of hands, how many of you here feel comfortable in all of these items? And there's probably more, elements of this Venn diagram that you can think of, but how many feel comfortable doing all of these? And I don't see anyone at Zoom, but I presume maybe some of you have, but not many. Most of us, yeah. So most of us don't have access or the knowledge to do all of this by ourselves and have the time to do this, right? So myself as a clinician, I'm a full-time clinician. I'm not a clinician scientist. And if you are a clinician scientist, that's because you probably have more of that scientific background. You may not do as much clinical time, and maybe you don't have as many exposures to the problems that you see on the ground. So there's, the collaboration is key, and that's the goal here. Understand that collaborating between clinical domains and technology domains and scientific domains is highly valuable. So let's talk about this infrastructure that we've set up that allows me to talk about these 5 elements that need to be present to achieve projects. So we'll go to one specific project that was done with the collaboration with Nisha's Health and Nandini and Ian. who've helped me kind of get through this project, which is a project on patients coming to the waiting room. We're initially waiting to get their x-rays based on the triage acuity. So when you come in, you have pain, you get a set of questions and a score appears. Your score is 1, 2, 3, 4, 5. 1, you have to be seen right away. 5, you could wait 5, 10, 12, 15, 20 hours. Depending on how you express yourself and how you feel, it also affects how the triage nurse understands your symptoms and the score that you get in the end. So imagine a patient coming in a wheelchair because he hurt himself, and has pain. Obviously, the final diagnosis is bilateral fractures on both sides, and they need a surgery. But along the way, physicians comes in or nurses comes in, they evaluate the patient. So what we know is that when a nurse sees a patient at triage, they can order certain tests, not all of them. So again, about 4 years ago, the director of our emergency department at that time decided to implement this nursing-initiated collective order. So the nurses can go through an algorithm and choose the test they want to order, and they have to run by a physician that's nearby. That's okay. But they can do that at triage and say, okay, this person needs an x-ray of the wrist. Physician so-and-so who's here, do you agree that I can do that? And the physician say yes, they will order it for that physician. What that does, it cuts down the time from being seen by physicians in 3, 4, 5, 6 hours from now, and then getting that test ordered. So really, you advance the time at which we order the test. So we know that collective orders of this nature can improve the time spent in the emergency department. So we wanted to know if our specific implementation of this X-ray collective order made an impact. Theoretically, it sounded like yes, it would make an impact, but we weren't seeing that clinically. We were not getting that clinical benefit where patients were leaving the emergency department faster. So this was implemented, and retrospectively, we analyzed the data of the study, and then we initially thought of it as, okay, so let's see the pain points. Patients are complaining that it's taking too much time for them to get that x-ray, even though the nurses could order it. The physicians are frustrated, being disturbed by, oh, can I get this x-ray while I'm typing a note or dictating a note? That interruption of that question frustrated some of them, and the administrators were not seeing the benefit. So we thought we could use a system perspective, a user perspective, data perspective to analyze the data. And obviously the answer was, let's use that data perspective to understand. So we made an ethics proposal, and ethics said, look, you're looking at retrospective data. You're not affecting care. You're not proposing anything. You're just looking at analyzing data. And at that time, they said, you don't need ethics. We defer you. Your methodology seems appropriate. Go ahead. You can access the data. The data is available in MedGeorge. I don't need to go to anyone else. So because we bought the analyzer module from MedGeorge, we extracted it. The analyzer module is a series of Excel files that you download for the patients, the x-rays, the disposition information, pain medication. It becomes quite clunky. So early on in my time here, I've decided to kind of automate this as much as possible. So we purchased a replica database from Legibec. So they've installed this for us. Exactly the same information that's in the analyzer module that comes with MedGeorge, but now we have a database that we can extract. Much easier to deal with rather than downloading individual files. You go and connect and query with SQL, that database, to ask the right questions.
We have a question in the chat.
Yes.
Actually, a few from Dr. Easer. Can you comment of the role?
I can ask them, Susan.
Go ahead, Nicole.
So I have two questions. One is more a general question that you could potentially address in the end. And then now that you're talking about MedEurge, maybe you can discuss who paid for the analyzer module, and is there recurring fees? Like, what was that, a hospital budget that paid for that? And whether you can search the consult requests with an LP for MedEurge.
Got it. Yes, I've understood both. So for the first question, so the hospital pays for MedEurge. The government.
So they paid for the analyzer module too?
Yes. So MedEurge is mandated, or an emergency medicine electronic system is mandated by the government. So the government has to provide funds to each hospital to buy their own. Back when people had the choice, majority of the hospitals in the province opted for MedEurge. So those who have MedEurge have access to what we call an analyzer module that's inside of MedEurge. The custodian of MedEurge, or the team that implemented at the MUHC, because we were one of the first and we've made significant improvements to MedEurge as a system, is the emergency department. So if you look in who's the pilot, who owns the system. It ends up being paid by the hospital from the government funds, but the innovations and improvements have been built in by the emergency department here at the MUHC. Therefore, we have sort of this joint ownership, and therefore we control the data that's in there as much as the hospital. So hospital extract data from the databases of McGill into that data warehouse. We had access to it through the analyzer module only. And a lot of hospitals have access to the analyzer module, but we bought this replica database. So the emergency department eventually bought the replica database that we pay with, I think, was a large one-sum fee because the infrastructure is set up really easily to have that. But I hope that answers the first question. And the second question is, can you query with NLP into McGill? No. But can you query through SQL into McGill and therefore build in a secondary tool that gets that data and then extracts it and queries with NLP? Yes. So that's kind of the work I've done using Python to connect to the database, extract that database, and then do the kind of queries that we'd want. Now, some of this is going to start sounding like MD Clone and the Adams platform, and it is, right? So what I'm doing in the emergency department is not any different from what the future system called EPIC of the province is supposed to provide, or what the Adams platform, the MD Clone platform is trying to do. It's just that because we had this joint ownership of McGill, we had the opportunity to go ahead and do these projects and kind of have access to the data. Now, how many people in my department have access to the data? Very few. Those who have a research ethics proposal get access to that kind of data, and they can go to the analyzer module themselves. Myself, with the permission from the DPS for clinical admin projects, I've been allowed to use it. And every time I want to do a research project, I go to ethics, get approval, and then I connect and get the data. So what we hold now in the emergency department is a mini data warehouse where I built this tool to read and extract and load data for clinical use, for clinical decision support in the administration side, not for real-time clinical use, but more for administration. And for research, I do get the raw data and restart all over. So, okay, so yes. Right. So the question was, how many sites is in my mini data warehouse? Essentially, MedSurg is only used at the MGH and RVH. The children's have another emergency department system, and Lachine, I don't think they have anything yet. Yeah, Sears, right? That's the one that the children's had as well. So how did this mini data warehouse happen, right? I think many of you understand the data warehouse that we have at the hospital. Well, similarly, we have one server that connects to that replica server of the MedJo's data, and then we read that data every 5 minutes to organize it in the way that I use for my projects. So that came about over a year of work where I had one project, a second, a third, eventually found the patterns to organize it in the way that I needed them. And a second virtual machine on which an analyzer setup runs for clinical operations. So both of these have been enabled by Python to be able to read the data and organize it, and then organize the way we'd want based on the timestamp. So not having heart rates alone is not very useful, but understanding the heart rate trend over time from arrival to a treatment intervention to later is much more useful and powerful. And that kind of granular data is not available in the data warehouse due to the nature of the initial data warehouse deployment was looking at data that's organized and coded the right way. So some diagnoses are there, the triage score is there, but granular timestamp were not all imported because there wasn't the standard. And often when I clean the data, I do find a lot of inconsistencies, and we'll talk about one of them. So about a year of work to kind of be able to understand this data, organize it, to be able to leverage it for project. And so we're back to this project of this X-ray collective order. So got the deferral from ethics, got the data, extracted the data using my little data mini warehouse, and then we were looking at the timestamps. So some patients, got their X-rays right after triage, but the collective order flag, which we call the CO flag, was not turned on by the nurse because it's a recorder issue. Nurses have to click everything that's in MedSurg, though it's digital. It's user input, right? So there's a delay in the user input. They click later, they forgot to click, it's absent. Some of that you have then, there's a series of different things, but some of that had to be retrospectively analyzed. So if a person comes in, gets an X-ray, gets a diagnosis of fracture, and gets a consult and gets discharged, that seems like a very traditional flow. But if the system says they arrived, they got the consult for fracture, then the X-ray, there's something that's wrong here that was not recorded, or there's a second X-ray. So we had to kind of analyze these different pathways by kind of drawing the timestamps and seeing which one didn't make sense. So with the help of the TAU people and the evaluation, able to go back and forth with this data cleaning process to organize the data in the effective way. And then you still have questions about, I had a gender that was X. There's only one patient in that entire data set for that project that had the gender X. And that is the reality. So we had to figure out how to do that. In my ethics plan, I didn't have that. So we dropped that variable, that patient, and excluded them. And if it was a research project, you'd have to kind of mention that in your project. Some of them had series of X-rays the 2 days later. But then you had to realize that if an X-ray is done 2 days later, was the patient admitted, and therefore exclude that from your data set. So there's a lot of exploration that has to happen when you look at the raw data. Often when we go to data warehouse, they like to give you organized, clean data. You may still need to clean more, but it's already organized and they've already made sense of this. Because we're dealing with the raw data, that ends up being on our task to do it. Obviously, that's another source of error and bias that we can bring in if we don't do the data cleaning properly. So the other problem that I've had, and this collaboration that's helped me, is to have the right methodology to answer the question effectively. Given ethics said, this doesn't have a significant ethical impact, you can go ahead and do your project. The collaboration, and I think was Nisha and Ian mostly, have helped me understand the right methodology to assess this patient population was that collective order was available as of a certain set date. I thought a year before and the year after was okay to compare. But it turns out that throughout that year, not every single person that was eligible for it got that X-ray. And that depends on the nursing, the training they got, how busy it was, an evening shift, day shift. A nurse that works once every 2 weeks may not be as aware and up to date with these protocols. So then we use propensity matching to find cases that were similar. And then we had to reflect on that, things that I hadn't thought of initially and it worked in my initial ethics plan. But this is where and I think some of you may have realized now I don't have a PhD in, research methodologies or in epidemiology. I'm coming from the clinical and engineering background. So this collaboration really helped. So right now, we're in the process of writing and publishing. And as you know, that's another set of headaches that requires hours and hours of work and dedication to get to. We're not really talking about today, but that's part of the whole deal if you want to publish something. So when we come back to the fundamentals of this project, so this X-ray collective order required the clinical domain expertise that I brought in with my nursing colleagues, helped me reflect. The raw data could have come from these sources, the MUHC, the InfoCent, or the emergency department data set that we have. The original database could also be queried with the analyzer module, which is McGill, and the analytics tools that we have. We can go to the InfoCent to do this, but it's not a high priority project. It doesn't affect patient care. It doesn't affect decision at the administration level. Therefore, it would be a low priority project for the InfoCent and would have had to wait months. So we did it ourselves with the help of TAU. So, fundamentally, it's just a general summary of this project is that the use of collective orders, as expected, decreased the time to disposition for these patients. However, the use of this collective order was not being done consistently. And then we noticed that if we did it, we maybe either we had to analyze a bit more, but we should do some educational incentive to empower the nurses to be more proactive at using it and maybe expand to other types of injuries. We might be able to have a greater impact in the emergency department. So once the gaps were closed, we were able to do this project. But then this becomes a rinse and repeat. Your next clinical question that's data oriented, you have an infrastructure, you have collaborations, you have methodology, you have people, and you can repeat the questions of various collective order. And we create collective orders on a regular basis at the MUHC, but we don't always evaluate the impact of them. Another project that kind of stemmed from having built that infrastructure and experience from that tool was the predictive AI modeling for which geriatric oncology patient is going to get admitted as soon as possible. So we managed to leverage a larger set of data. This time, ethics required more ethical evaluation. The EFVP, which is the board that evaluates patient impact of their privacy, got involved, and we got access after a year to that data, and we started analyzing it. And that data came partially from the data warehouse, the lab information system, and the MedGill system. And we had hired a master student from Mila, and my colleague and I from Radonc and I had worked on this project that's still under writing up for publication. Other projects that became much simpler to do is to build a Power BI on that mini data warehouse that we have for my nursing team to be able to evaluate turnaround times for urine analysis for every single other lab test. So once they built it for urine analysis, we just changed the flag for a different lab test, and they have that system available to them right now to use. It's connecting the Power BI to that database that we have, and obviously organized to make it effective to load quickly. So they continue to evaluate for other metrics in the emergency department. The time to ECG when a patient comes, we have 10 minutes to the ECG and show it to physician, and we noticed that in the meantime we're around 20 to 30 minutes in a certain patient population. So now there's a target to improve that. And again, this, because it's clinical operations, the nursing team would have used the analyzer module, downloaded a set of files, and analyzed it. And if they wanted data for the next month, go back to the analyzer module, download. But by connecting databases and extraction processes with Power BI, they just go to that Power BI page, change the date frame, and now they have the data. So really empower them to kind of go forward and leverage the data. Going forward in the future, think of more actionable projects. We think of having a complete data set down to individual clicks for structured and unstructured data. So nurses write a lot of notes in our MedGill system. So, I'd say half the information is digital by clicks and timestamps and lab values, and the other half is notes written by nursing for every time they assess the patient. So being able to leverage that in real time would be powerful. And I think that's the idea of using NLP to query, what the patient's symptoms are and how they're evolving. A lot of text will be described as patient has a lot of pain. Patient's pain is improved after morphine. Pain is getting worse again and then getting better again. Is that an indication of my timer that I have a minute left? Okay. Yeah.
To explain more in the NLP processing, because like you say, you extract the data using the SQL query and then using the NLP from a local GPU like that, or like I think maybe it contains some of sensitive information, right?
Yeah.
Yeah.
So we don't use NLP yet, as more of it that we could once you have that text data available to you. So, and part of that is what you're saying. So for one of my projects with the AI algorithm, we got the approval to use the nursing texts, where there was a process we had in place there to remove anything that could be phone numbers, postal codes, names, to anonymize that, to extract that. But in the end, we didn't use that text data for other complex reasons, that it was just complicated to model. And the model was getting already too big that we dropped that part. But the idea is that if you have data on a server with all the right permissions, it's nowadays a matter of implementing the right libraries to be able to run whether simple word searching or more complex NLP or machine learning based natural language parsing, but also like the AI models that can make sense of that text, right? Like summarizing that text and so on. But that would require a GPU. Now, I did try to implement a MedGemma model in the hospital on our server that we have access to, but we don't have GPUs in the hospital, and therefore they're extremely slow. So you'd have to get outside the MUHC, go into a Compute Canada or some other platform, but then the boundaries of that make it much more complicated to get approval. So whatever stays in the hospital is a lot simpler to achieve. Yeah, so I think I was here. And the idea that we have, I guess Zoom people can see, yeah. So the idea that we often do research, and especially in our department, with files that you download, whether you impute yourself. But if you connect the data sources and create those extraction processes for the ED in the way we do projects and build upon them to improve them, future projects become easier and easier to achieve. Like I was saying, Now that we have access to, turnaround time or one specific lab, we can do it for all the labs. So we need to kind of move towards projects that set up infrastructure. So I think really coming back to the MD platform, MD clone platform, the Atoms project, which is a bit of that at a hospital level. Eventually, it'll have all the right data set for the emergency, but at this point, it doesn't. But that's the right pathway to move forward, to be able to do projects the whole mechanism of collecting, organizing, cleaning data needs to be facilitated, so we don't all do the same steps again and again. But also connecting to live systems or live research systems allows you to click through and get the next batch of data. And updating that every hour, every day, depending on the need. Clinical systems versus administration systems versus research don't all need to be updated at the same time. And the MUHC data warehouse is only updated every 24 hours, which is not ideal for some types of projects. Yes.
Yeah, I have a question. I mean, it seems to me that, there should be greater collaboration. I'm not saying, between the MUHC data warehouse and the emergency kind of mini data warehouse. Because, for example, we have a project we're trying to do where we would have loved to have data from the ER, but it became too complicated to get, for example, the main diagnoses and everything, because we would have had to go through, the diagnosis is not always easily accessible from what they have at the MUHC data warehouse. And so it would kind of elevate, potentially the research projects people can do if you could kind of go through the data warehouse for patients who then get admitted or followed in the outpatient. But if you need as well emergency room information or data, that there would be some kind of ability to access this as well. I don't know if that's going to happen in the future or if anybody has been able to do this previously.
Not that I know of. I think initially I spoke a lot with Robin Hamlin and David Buckridge to understand what are my resources to achieve this. And it really came down to you have to go to the data warehouse, get that data. You have to go to McGill, get that data, and merge the data together yourself. And my first project took about, if I was working on it full time, it would have taken me 6 months of just that to understand and do it. Now, again, the Atoms platform is exactly what you're mentioning, but it's a work in progress and it will get there. Otherwise, it's really to collaborate, if the questions are aligned with the needs of the emergency department, efficiency, workflow, performance, then I think there's an opportunity to collaborate with my colleagues or myself to share that data and move forward. But the data, as I think Dr. Ezra was asking, does not belong only to the MUHC. It's just that the data warehouse has become a scarce resource. That team doesn't have the time to provide data for everyone, and you cannot go and get it yourself. So it makes it trickier. But, I think we've had
So I'm saying there should be an intent to try to bring these two excellent resources together. I mean, why not?
Yeah.
I understand the issue of funding, but
yes. So just to close, where I see this future going, and it's a bit of what you're saying, is to think about things in improving decisions, workflows in real time. So do we need to call in a backup because we expect the prediction based on the weather and the type of patients and the hospital occupancy that we're going to get flooded in the emergency department? Should we call in the backup? Are there system failures? And you'd be surprised to know that if sometimes a lab test takes me 2 hours, I'll ask the question, why is it not back? And someone will eventually tell me, oh, it's been 3 hours, the lab system transport is down. Had I known, I would have prioritized this lab test for this one patient to bring it through a porter to go up and down and bring it back. So some of these system failures could be easily monitored and tracked in real time. It's not really complicated, but it's systems that don't exist. Or to automate tasks so that patients don't repeat themselves or physicians don't have to repeat themselves. Often I'll tell my nurse I want a certain thing. I'll type it in my notes. I'll click the buttons to order it in one system for part of it and another system. It's a lot of repetition that we can all save from. So that's overall my presentation to share you my experience of collaborating with all of you guys, to learn from the methodology perspective, doing my part in getting that data and organizing it and trying to make things better for patients. Yes.
Great talk. Thank you very much for presenting. So you touched on this a bit. I just want to get a more sort of comprehensive answer. It seems like there's a ton of substrate to make major improvements, especially the ER department. Like it's just the front line of
Yeah.
healthcare, and there's sometimes it feels like there's a lot of inefficiencies. So has there, and I could see how projects could manifest through individuals making observations. Like when I'm there, I'm like, I wonder if we did it this way, would it be faster?
Yeah.
And pursuing that. But one could also approach it much more systematically, where you go to the patients and say, what are your unmet needs? What are your priorities? You go to the physicians, and it sounds like you did that to some extent. Physicians, you go to the nurses, go to the administrators, because on some level, there's so much. Like how does one prioritize? Like where's the big opportunities where we should focus on cleaning the variables properly, making sure they're linked properly? Because some of the data cleaning you described and the nuances, and that's to me just totally every project I've ever encountered. That's the longest step, is meticulously going through the data. No matter how automatically it was generated, you need to look line by line and find these coding, whatever, just mistakes or weirdness. And that's okay. Like I think that's part of the, even waiting 6 months to get a dump of data, that's also not unheard of. And depending on the question, that's probably okay. If it's a chronic problem, it's worth waiting to get it done. But so all that to say, have you sort of embarked on that to sort of set the target on the major issues? And I don't know how you prioritize. The administration's priorities may not align with the patient's priorities or the physician. And that's a separate, interesting question to address. But anything?
I mean, I think your question is exactly a pain point that we have. Now that I've started to explore some of my projects with this and share with my colleagues, many are coming to me. I have this question. I want to do this. I want to do this. And then as a single resource to my ED, I don't have the capacity to do that. And in our emergency department, we don't have clinician scientists. And that's been one of the push for the last 5 years to get that, dual brain training who wants to do research and dedicate 50% of their time, or having PhD collaborators or PhD students. I think there's probably one or two of us who are affiliated with either a biomedical engineering department or the tradition. You guys changed names recently. The translational research.
Yeah, right. Clinical and translational research.
Yes.
Graduate program.
Yeah. So to be able to collaborate with master's students and PhD students, but otherwise we're all clinicians. So we're all full-time clinicians, and I think that's probably the infrastructure problem that we have. We don't have a research brain running in our department, despite having a research director who is a full-time clinician. So I think that's where we start having our problems. To me, the reason to do these projects was not for pure research, was actually to improve clinical workflow. So since having done this, we've developed a little pilot project where we aggregate all this data and then could now add alerts for medication errors or connect with MedSafe and kind of say, oh, this patient needs to be weaned off certain medication. Like we're there, we can do these. But that was the goal for all of this learning, to understand the databases, to the projects, so to get there. So I think, had I been a clinician scientist, the next step would be to collaborate with PhDs and other departments to kind of move forward in that perspective. But we're lacking that key resource in the emergency department. We haven't been able to convince anyone to do that yet. So that's where it says, but the problem is very real.
That's why you're talking to us.
Dr. Easter, you had a question. You had your hand up. Do you still have a question? I'm going to go with no. In the room? There's one in the back, one in the front.
I don't think it's fair for any project to get done without funding of some kind, because it's not just you, the person, the doc or the person with a PhD or MD PhD. You need research assistants who can go through and help. That doesn't need to be done by the doctor or the PhD. So we do have in the Department of Medicine, right, quality improvement project. Every single division is supposed to be doing that. And given that a lot of the quality improvement needs to be done in the emerge, maybe we can think of that as a model. But then there is also that solving the stay. Isn't that emergency room related? That's a source of funding, right?
Yeah, the solve the stay is what it's the MD Clone Adams platform. So Antony talked about that. But yeah, I mean there's multiple projects going on, and I think the solve the stay is supposed to be part QI, so the QI platform, but also including researchers. So I think that's the underlying problem, right? When we say QI, we just assume that this is a hospital priority and that they should be improving quality of care, right? It's part of the hospital, but there isn't funding per se back written into it. Yeah.
Yeah. So, I just to comment on that, all my funded were unfunded till I got the MUHC Foundation take pity on me and then provide me for fund for one project. And that really helped alleviate time for that by hiring master students. But otherwise, we are at the emergency department is a separate department from medicines. We don't have access. So unless we do a collaborative work. Yeah. Thank you.
Thank you very much for a very interesting talk, Antony. I presume the collaborations with TAU have in part, been a source of funding, right?
Yes,
right?
yes. That's true.
And this TAU does fall under DQEPE. And my own question is, so what happens to the knowledge you've gleaned from these analyses? Do they become policy? Is there a formal mechanism to implement what you've learned? Or, I mean, I would hope they don't just stay in some report somewhere.
Yeah. So, the first aim was to try to publish these to kind of build a bit of a research curriculum that allows to fuel more funding and so on. So at this point, most of the projects were the ones we talked about are more for publications. And so they're kind of work in progress towards that. The collective order is one that will work in the ED to the extra collective order to expand on other collective orders. So it provides the nursing department motivation to continue rather than change what they do. There is the project where we analyzed the impact of the high sensitivity troponin that was implemented about 7-8 years ago. That one led to some changes in the hospital where they were running the test twice, given it was a new test and they were worried of false positives. And we reported to them how there's an impact and delays to getting that first test result if they're running it twice and it's positive, rather than being an hour, ends up being 3 hours to wait to get that test result. And they recently looked at their data and changed the way they're doing it. So they're now running the test once because the false positive rate is extremely low and not worth the delays that it was causing. So that came from that research project with Dr. Brophy and bringing it back to my department, going back to the lab team, and they've kind of made a change. Not as a formal policy that was described, but they've evaluated, made the change, and it's now in place. But it happens sort of like as a grassroots initiative where somebody hears about it and say, oh, we have to do something, and then they've done it rather than a specific policy perspective. All right. Thank you very much for listening to me and sort of enjoying this data-driven perspective. I think it's now the modern age, and I hope more of you will continue to strive towards that and maybe collaborate with me or my team.
Thank you so much. Thank you.